The question is, why should we measure AGs? We have a lot of measurements of glucose metabolism. And let me present you some glycemic values of one patient over several days. As you can see, there is a they fluctuate a lot. Of course, these curves are important for us as the physicians because we can adapt our treatment. But not always we can properly interpret them. That's why when we want to judge the goodness of the treatment of our patients, we take the HbA1c, which you heard is actually a precursor of AGs, an Amadori product, and this helps us clinically. But we have to consider that even the HbA1c is a measurement that mirrors the blood glucose control of the last about 3 months. And these are the HbA1c values of one of my patients measured every 3 months. So you see that there is quite a lot of fluctuation also in HbA1c over years. But if we want to anticipate cardiovascular risk of one patient, it's not enough to measure just one HbA1c. We have to take into account maybe the mean HbA1c of several years. And actually, the measurement of skin autofluorescence does exactly this. This is a study from Japan that showed that skin autofluorescence significantly correlates with the HbA1c measured during the last 15 years. If you look in PubMed at data that were published using skin autofluorescence, I find it amazingly because it's a small device. It's not very, it's quite recently came on the market, and nevertheless there are excellent studies published in high-ranked journals. And what I will try to do is just try to summarize the evidence that we have for you. Why using skin autofluorescence, and why using maybe the AGE reader? Because the measurement is well validated. There are studies published in patients with diabetes, in patients with renal disease, in controls, that validated this measurement against measurements of AGEs at the site of the measurement, which is the forearm. The investigation, as you had the chance to see outside, is very easy to perform. And it's also very easy to teach your personnel to perform this investigation without the presence of a doctor. And it's very rapid. You have the result within 30 seconds to maybe 1 minute. Of course, you have to take into account that you also have to prepare the patient, but nevertheless, you have the result. It has a good reproducibility, and we tested this reproducibility in a study that we published a few years ago. We looked at 22 patients with type 2 diabetes that were repeatedly measured using the skin autofluorescence, and we were able to show that the intra-individual variability of skin autofluorescence, when the measurement was repeated after 6 weeks, was 6.9. When you wait a little bit longer, 12 weeks, the variability increased a little bit to 10.9. But you have to take into consideration that within 12 weeks, also something happens with your patients. So it's definitely not a matter that relies on the inexactitude of the method, but also it relies to the physiological changes of your patients. And another study group, Mulder, had already published that the intra-individual variability within 1 day lies at about 5%. A very important issue is that if we perform an OGTT or we measure fasting plasma glucose, patients have to attend fasting, our unit, which, as you know, is not always easy. And one of the advantages of this device is the fact that it does not require fasting patients. And this is something that we also measured within that study. These 22 patients with diabetes were repeatedly measured after 4 times receiving a meal, and we perform measurements before meal, 2, 4, and 6 hours postprandially. And we measured the coefficient of variation for skin autofluorescence and found that it was 3.6%, so very low. You have to take into account that skin autofluorescence increases with age. That means that always when you like to interpret data of your patient, you have to look at the normal values of his age group. And you can see here data published by Lüdkers and co-workers that also establish some normal value, if you want, for different age groups in the middle. And if you look at patients with diabetes in the same age range, you can note that patients with diabetes have an increased skin autofluorescence at any of age ranges. And this is a fact that was used afterwards for investigating whether skin autofluorescence can be used for screening of diabetes mellitus. And this is a study performed in over 350 patients with risk factors for diabetes that received measurements of HbA1c, fasting plasma glucose, and also skin fluorescence. And they were diagnosed with diabetes, or diabetes was excluded using an oral glucose tolerance test. And the authors were able to show that measurement of skin fluorescence had a better sensitivity than fasting plasma glucose and HbA1c, and identified almost 30% more diabetic individuals than the fasting plasma glucose, and around 17% more individuals than HbA1c. And this principle was used by another study by Smith and co-workers that was able to show that measuring skin autofluorescence and using also an algorithm for diagnosing diabetes and then referring patients to an OGTT to confirm or infirm the diagnosis diabetes, that this algorithm and skin autofluorescence was superior to fasting plasma glucose and not inferior to HbA1c. That means that actually, without further laboratory values, you can decide by using this algorithm and also by measuring skin autofluorescence whether to do further diagnostic in order to see if the patient has a diabetes or not. Not only can be used skin autofluorescence for screening for diabetes, but also for screening for diabetes microvascular complication. And this is a study performed in over 560 patients with type 2 diabetes, where microvascular and macrovascular complications were investigated. And authors build it in the end for groups. And as you can see, patients with diabetes and no complications had the lower skin autofluorescence, which increased in patients with diabetes and microvascular complication, further increased in patients with diabetes and macrovascular complication. And if those patients had both microvascular and macrovascular complication, then they also had the highest skin autofluorescence. So the more complication the patient has, the higher seems the skin autofluorescence to be. Several studies have also investigated whether the skin autofluorescence correlates with some specific diabetic microvascular complication, like this study by Chabroux and colleagues showing in patients with type 1 diabetes, the skin autofluorescence is associated with nephropathy. The further two studies from Japan were able to show in patients with type 2 diabetes that skin autofluorescence is associated with retinopathy. And one observational study with a large number of patients, over 880, with type 2 diabetes that were observed for around 3 years, found that skin autofluorescence had a good predictive value. Odds ratio was 2.05 for neuropathy and nephropathy. And this predictive value was superior than that of HbA1c and diabetes duration, two parameters that we usually use in order to calculate the probability that the patient develops microvascular complications. not only skin autofluorescence correlates with the presence of certain diabetes complications, but it also seems to correlate with the severity of these complications. And this is a study performed in 240 patients with diabetes and also in over 100 controls that found that actually skin autofluorescence here on the left increases with the severity of retinopathy and also increases with the severity of chronic kidney disease. Pretty much the same applies also to the presence of diabetic polyneuropathy. And this is a study in 24 patients with history of neuropathic foot ulcer. The second group was built out of 23 patients with diabetes without neuropathy, and there were also 21 controls. And as you can see, skin autofluorescence in controls, as expected, was very low. It increased in patients with diabetes but no polyneuropathy, and was highest in patients with diabetes and polyneuropathy. And what was also very interesting is the fact that when authors looked at the extent of foot ulcerations, according to the Wagner classification, the patients that had larger foot ulcers also had the highest skin autofluorescence levels. With respect to macrovascular disease, several studies have shown that skin autofluorescence correlates with early vascular changes, like for instance vascular stiffness, intima media thickness, and overt atherosclerosis. And that's why the question arises, can we use skin autofluorescence in order to predict the risk for cardiovascular complication within the next 10 years? And you know the UKPDS risk engine that uses several parameters in order to calculate how high the risk for fatal cardiovascular complication within the next 10 years is. But the UKPDS risk engine just tells you if the patient has a low risk, that means below 10% to develop within the next 10 years fatal cardiovascular complication, or high, over 10%. It's very simple, but the question is it enough? And this study shows that it's not enough. In this study, patients were not only stratified according to the UKPDS risk engine, but the skin autofluorescence was also measured. And you can see that two groups, in the low risk group and in the high risk group, further two subgroups were built. On the left, a subgroup that had a skin autofluorescence lower than the median, and on the right, a group that had a skin autofluorescence higher than the median. And what you can see here, patients with a low cardiovascular risk according to UKPDS, but increased skin autofluorescence, had an event rate over 10 years of 17.8, which already allows us to classify them in the high risk group. And also, the subgroups in the UKPDS high risk group, the ones that had a low skin autofluorescence had around 40% event rate over 10 years, and those, they had the highest skin autofluorescence value, had an event rate of almost 56%. That means that if we add the measurement of skin autofluorescence to the UKPDS risk engine, we can reclassify and more accurately classify the cardiovascular risk of our patients over the next 10 years. Another study has investigated skin autofluorescence in patients with carotid artery stenosis and patients with or without peripheral artery disease. And as you can see here, controls had, of course, lowest skin autofluorescence. Patients only with coronary artery disease had a higher skin autofluorescence, and if patients had both coronary artery disease and also peripheral artery disease, their skin autofluorescence was very, very high. This is also a study that was performed in Japan, 122 patients with type 2 diabetes, where skin autofluorescence on one hand and on the other hand, the calcium coronary score was calculated, And authors found that patients with no coronary calcification on the left were also the ones that had the lowest skin autofluorescence. Patients with a somehow higher, with a higher score, but below 400, had a higher skin autofluorescence, and those that had a calcification score over 400, which is very much, had also the highest skin autofluorescence value. And the same study found out that skin autofluorescence was a better predictor for a calcium score over 100 than pulse wave velocity and intima media thickness, two of the established parameters that we use in order to find out if our patients have also some other cardiovascular diseases. What about skin autofluorescence for the calculation of mortality? This is one study performed in type 1 diabetes, type 2 diabetes, and also in control subjects that were followed up for 5 years. And the conclusion of the authors was that skin autofluorescence was strongly related, on one hand, to the presence of coronary heart disease, but also predicted very well mortality. And let's have a look at these Kaplan-Meier curves that maybe give us better information. Those patients that had a skin autofluorescence below 2, it's not a mistake. It's written 002 here because this study was done with a prototype of the device. We just have to multiply it by 100. So those patients that had a skin autofluorescence below 2 had also the best survival rate over time. The ones with a skin autofluorescence between 2 and 3 had a somehow increased mortality. And those that had at the beginning a skin autofluorescence over 3 had a dramatically increased mortality over the period of 5 years. So skin autofluorescence in this group of patients with type 1 and type 2 diabetes can be used to see which patients are at highest risk. And skin autofluorescence can be used for predicting mortality also in a group of patients with a very high risk, in this case with patients with hemodialysis. This was a study where patients were followed up over 3 years. And as you can see here, skin autofluorescence was found to be an independent predictor of overall mortality and also for the cardiovascular mortality. The odds ratio was 3.9. And also easier to understand maybe if we look at the Kaplan-Meier curves, those patients that had the skin autofluorescence in the lower mean had also the best survival. Those having a skin autofluorescence in the upper mean had the most impaired survival at the end of the study. And if we want to be a little bit more specific, we can take into account not only the skin autofluorescence, but also the presence of coronary artery disease or cardiovascular disease in this case. Those patients on hemodialysis having a low skin autofluorescence and also no known cardiovascular disease have also the best survival. Those with an increased skin autofluorescence but without known cardiovascular disease have an somehow increased mortality, and those having both increased skin autofluorescence and also known cardiovascular disease have also the poorest survival chance. So let me summarize. The measurement of skin autofluorescence is easy to perform. It is also a measure of skin AGEs. It is reproducible. In most of the studies, it was found to be more sensitive than classical parameters like HbA1c and fasting plasma glucose. And there are several studies showing that this parameter can be used for the screening of people with diabetes, for the screening of patients with diabetes for microvascular diabetes complication. It can be used for calculating the prognosis of development of diabetes complication, and it also can be used to evaluate the risk of patients to die. So, Mark Twain said many years ago that it is difficult to make predictions, particularly about the future. But I would dare to say that I think that the measurement of skin autofluorescence will develop to an important tool in clinical practice within the next year because it's very easy to use. We have nowadays also very good reference values, and we have studies that demonstrate that we can use this parameter for several clinical indications. So thank you very much for your attention.